I think we should move on to the next section. Simon?
Yep, I agree. Yeah.
Yeah.
Let me just see. So, I believe. So we now move on to the third section of the webinar, which is on ocular traumas. And I would like to welcome our three speakers for the evening. So I think it's Dzinic Ozmen from Turkey, who will discuss the chemical and thermal injury at the acute management. Michael Tsatsos from Greece, discussing sharp trauma, corneal lacerations versus penetration, the assessment and referral. And finally, Dr. Vladisnav Dzinic from Serbia, discussing blunt trauma, Hyphaema, and versus rupture. Again, the assessment and referral. So thank you.
Dear colleagues, I'm going to present acute management in chemical and thermal ocular injury, and I have no relevant financial interest. I'm going to give basic epidemiological data and focus on acute management of chemical and thermal ocular injury. Chemical and thermal ocular injury comprises up to 18% of all ocular trauma, and it is one of the most urgent ocular emergencies out there. I'm going to focus on chemical ocular injury from now on because direct thermal injury to the eye is rare, and rapid blink reflex protects the eye from thermal source, and eyelid takes on the majority of the insult with late lid contractures and exposure keratopathy later on. And the acute management is similar to chemical injuries. A patient admitted to ER usually goes through several examination steps prior to receiving a treatment. However, previous evidence suggests that treatment should be prioritized over immediate ocular assessment in case of chemical ocular injury. But who is treating? Usually the first line of people who treat chemical trauma are bystanders, and they are family members or a friend who are non-medical professionals. Later on, emergency medical services and first responders come into the picture. However, they are non-ophthalmologists, MDs, nurses, or physicians in training. So bystanders and first responders have a crucial role in the treatment of chemical ocular injury. Public education is important because our goal is the immediate removal of the offending agent and copious irrigation of the affected eye. Time to initial irrigation has the greatest influence on visual prognosis. Prior to irrigation, disinfecting hands with an alcohol-based hand sanitizer is not recommended because it could cause further irritation if it gets into the eye. And topical anesthesia by a local anesthetic drop is helpful to relieve the symptoms and help with the irrigation. But keep in mind that anesthetic drops should only be used during the irrigation and should not be prescribed to the patient. So how long should we irrigate? Classic teaching tells us that 30 minutes or 2 liters of irrigation is enough. However, current guidelines suggest continuous irrigation until the ocular pH is restored. So we should check for the ocular pH every 30 minutes. And how are we going to check it? An ophthalmic pH meter is very hard to find in ER, but we can find a widely used pH meter, which is in a urine dipstick. The pH box is in the middle, so we have to cut the dipstick and then use it in the fornix. And we need to stop irrigation for 5 minutes for optimal pH acquisition. Use of alkaline or acidic solutions in an attempt to neutralize the chemical burn should be avoided at all costs. And irrigation of a chemical injury should take place at least 30 minutes, but most likely it's going to take more. There are many eye wash brands that are out there for public use, and a number of studies have looked for the best agent for irrigation. And certain solutions containing buffering agents have been proposed as ideal. However, even tap water is an appropriate irrigating solution. So the best rinsing solution is the one that is available. Morgan lens is another important asset that should be used with topical anesthesia to facilitate the irrigation process. But keep in mind that this lens has a disadvantage of not being able to push away the chemical remnants in the fornix because it blocks most of the palpebral fissure. There are many factors that affect the severity of and prognosis after chemical injury. but the most important factor is the time between the insult and the irrigation. Delays in the initiation of irrigation by as little as 20 seconds have been demonstrated in animal models to result in a higher maximal pH at the end. The importance of chemical injuries lies within the limbal stem cell injury that they cause, which leads to ocular surface diseases and which in turn leads to melting, perforation, and blindness. So we learned that chemical and thermal ocular injury is one of the most urgent emergencies in ophthalmology, and immediate neutralization of ocular pH, it has the utmost importance. Thank you.
Good afternoon, this is Michael Tsatsos, and I'm going to talk about sharp ocular trauma, corneal laceration, and penetrating ocular injuries. I'd like to thank the organizers for their kind invitation. I hold no commercial interest in anything discussed in this talk. So, from a definition point of view, corneal laceration, corneal penetrating injuries share a very similar mechanism. However, corneal laceration does not involve any tissue loss, whereas corneal penetrating injury does involve tissue loss. Another common differentiation of ocular injuries is between penetrating and perforating corneal injuries, with perforating injuries having both an entry and an exit point. As always in the assessment, you start with a very good history, noting the nature of the injury, the mode of action, the location of the injury, and we should always make note whether the patient was using any protective equipment and the use of prescription or any other type of glasses, because these can be shattered and therefore foreign body glass in this case could enter the eye. Whether the patient is amblyopia in the injured eye or in the other eye is quite important, the use of medications, and especially tetanus immunization status. The clinical examination, of course, as ophthalmologists, we use a slit lamp. The slit beam does help us with the assessment of the AC depth. We should not forget transillumination, retroillumination. As we can see here, it can help us with the location of foreign bodies in the iris. It's not easily seen. Otherwise, use of fluorescein does help very much differentiate whether the injury is full thickness, so there is communication between the AC and the outside, the environment. As we can see here, the dilution of the fluorescein just proving a leakage from the AC. Another telltale sign where the injury is, the corneal injury is full thickness, is the presence of pigment in the wound, suggesting violation of the iris, and as we can see, for example, here, violation of the capsule and the lens structures. However, in this case, it is surprising that the intraocular pressure was normal. The reason is it was plugged by iris and possibly a little bit of fibrin. We should be quite careful with the pressure in the eye, avoid gonioscopy and scleral depression for the assessment of the retina, which of course should be done, and it can be done with gentle ultrasonography. In cases of suspecting foreign body, we should have a very low threshold for scanning, CT scanning, orbital protocol, meaning very thin 1 millimeter cuts. And as most foreign bodies are of metallic nature, we should avoid magnetic resonance. So what to do next? Of course, that depends on the injury and the type of injury. However, all patients should be covered with broad spectrum gram-positive and gram-negative antibiotics, topically and systemically. Superficial laceration, especially centrally, could be encouraged to heal with the use of bandaged contact lens, as we can avoid, in that case, high risk of astigmatism, of sutures. Peripheral laceration, especially if there is gaping, of course, we need to use sutures, as we can see here. In cases of tissue loss, cyanoacrylate glue, at least as a temporary measure, can be used. We can see here placement of cyanoacrylate glue and a little bit of plastic from the drape that goes directly onto the crater and needs to be covered by a soft bandage contact lens because the surface of the glue is quite rough. In more severe injuries, the patient needs to be taken to theatre with general anesthesia. Of course, these injuries are usually full thickness corneal injuries with or without the presence of a foreign body. In those cases, a shield should be placed on the eye. The patient should be made comfortable and kneel by mouth for the preparation for emergency surgery. I'm sure our anesthetist colleagues are aware of that, but we do prefer general anesthesia because ketamine and sodium calling for sedation do tend to increase the intraocular pressure, increasing the risk of intraocular content expulsion. I'd like to thank you for your attention, and of course, I'm available for discussion and questions. Thank you.
Dear colleagues, thank you very much for joining us to this SOE ophthalmology webinars. My name is Dr. Dzinic, and my topic today is blunt trauma. One of the most important things when we see the injured eye is in the management process is to determine the type and the extent of the injury. How can we achieve that? By ophthalmological evaluation, which includes the history, how the injury occurs with the visual function testing and different kind of examination with the help of imaging techniques. Hyphaema is the most commonly diagnosed pathology. The incidence vary depending on the type of the injury, and it usually clears spontaneously within the days throughout the trabecular meshwork. It is very important to say that according to some studies, more than 50% of the eyes with trauma-related hyphaema showed some types of the posterior pathology. Evaluation of hyphaema, the slit lamp is the best tool to identify it. Visual acuity and intraocular pressure can vary, and it depends from the quantity of the blood inside the anterior chamber. Various methods are presented to describe the size of the hyphaema. It can be presented in millimeters, it can be presented in percentage, or even in a clock hour when we use the meniscus of the blood compared to the corneal limbus. Treatment of hyphaema is usually medical. We use psychoplegic mydriatics to reduce the pain in synechia, topical corticosteroids to reduce the inflammation, and anti-glaucoma treatment if it is necessary and if we have an elevation of intraocular pressure. Aminocaproic acid or the TPA can be added in order to reduce the incidence of rebleeding or to speed up the clearing of anterior chamber. No patching and no hospitalization is needed, and in severe cases, surgery can also be the options. Complications of hyphaema include recurrent bleeding, corneal blood staining, and glaucoma. So what is important when we speak about the hyphaema? It is important to rule out, first of all, the systemic disease, to try to prevent the corneal staining by lowering the intraocular pressure. And one of the most important facts is to exclude any other ocular damage. On the other side, rupture of the globe is the most severe type of the injury. Rupture sites are rarely at the site of the impact. It is usually at the limbus, at the equator, behind the extraocular muscle insertion, lamina cribrosa, or the site of the previous eye surgery or any other site. So when we see the patient with injury, which is caused by blunt trauma with substantial momentum, if we found in a history that that eye has a previous ocular surgery, that it is high myopic patient, if we found out the significant visual acuity loss, even no light perception, usually lower intraocular pressure and afferent pupillary defect, all of these facts can lead us that suspect that this is the case actually of the rupture of the globe. Other anterior or posterior segment signs actually vary, and depending from the force of the blunt object, strands of the vitreous, which are covered with fresh blood pointing in one direction, can actually lead us to the site of the rupture of the globe. We must evaluate every eye specifically, and not just follow the protocol, and we must close the wound as soon as possible in order to prevent explosive choroidal hemorrhage. So when we see hyphaema and the rupture and compare it, hyphaema is usually caused by force which is not so extensive. It usually medical medical treatment is in most of the cases enough. And the most important thing is to rule out any sign of posterior damage with the help of different imaging techniques. On the other hand, rupture of the globe is very extensive. It's damage of all of the structure. We must take care of occult multiple ruptures and to try to prevent secondary complication due to tissue prolapse and scarring. Of course, imaging techniques are helping us to confirm that, even sometimes explorative surgery, and the treatment is immediate surgery. Thank you very much for your attention.
Thank you, Cuynet, Michael, and Vladisnav for your great presentations. We now have the chance to discuss the talks we have just heard. So we have a few questions here. First question is about the chemical injury. So my question is that in situations where water is in short supply, would you have any other preferred substance to irrigate the wound? And also a second question, what is the role of amniotic membrane in chemical injury?
Can you repeat the second question, please?
Yeah, the second question is, what is the role of amniotic membrane in chemical injury?
Okay. For the first question, of course, any irrigating solution that is around the neutral pH can be used. For example, usually we can use even milk. However, there is a problem with that. The pH of the milk is a little acidic because of the lactic acid in it. However, it's close to 7, so we can use whatever we have in order to neutralize the pH, because usually the chemical agents that are around us are in the wide range of pH, like close to 1 or more than 9. So we have to use anything that is available. For the second question, of course, amniotic membrane is a very important asset for the treatment of chemical trauma. There are many advantages to it, because it has antimicrobial properties, it has anti-inflammatory properties, it has tissue reforming abilities because of the cytokines in it. So it is a very good asset, but of course, prevention is more important than the treatment in this case. We use amniotic membrane or autologous serum tears for the treatment, and we use it if the epithelium is not healed clearly. But again, prevention comes first, and that was the main idea of my talk. Thank you.
Thank you. So this question is for Dr. Tsatsos. So in case of traumatic cataract, shown like in the picture of the corneal perforation, how long do you usually wait after the primary repair before you consider secondary surgery, such as the cataract surgery and vitrectomy?
Yeah, so there is a little bit of a debate whether you go ahead and you operate the cataract at the same time as the primary surgery. Of course, it makes sense to do the cataract itself if there is, for example, a foreign body in the lenticular tissues. It depends a lot on the access and the presentation of the patient, whether there is a tiny foreign body, for example, that is quite superficial, and the whole trauma is causing a little bit of cataract. This can be diverted to a few weeks when everything is normalized and the eye looks a lot more set. Number one priority is fixing the globe, the integrity of the globe. And number two is fixing everything else. I do appreciate that there might be a little bit of a uveitic response to that. and that can be controlled and treated until everything is a lot more set for the eye theater and the team to go ahead with cataract surgery. So to summarize, it can be done in one go. A lot of centers do prefer to do it separately, especially if, for example, the initial trauma is quite superficial, and then to do the cataract surgery after 2 to 3 weeks.
And then I think we have one last question for Vladisnav. So is there increased risk of causing an acute secondary glaucoma if we use cycloplegics or mydriatics in patients with a large hyphaema?
Well, we didn't notice that, because when we see that that kind of patient with a quite large hyphaema, we usually prescribe some eye drops in order to lower the pressure, even if sometimes it's on the borderline, just in order to prevent that something can happen because of the widening of the pupil. But we're not using long-acting mydriatic. We're just using tropicamide or phenylephrine, just to trying to play the game, to leave the pupil to play, not to make synechia, to prevent of forming the synechia because of the constant size of the pupil, let's say. But we didn't notice any problems with the pressure because of that.
Okay, thank you very much.
If I may say one more thing, there might be, of course, a combination of mechanisms. For example, there might be a thermal injury associated with a sharp injury, or a chemical injury associated, let's say, burst pipe with a foreign body. So I think all these thoughts can be slightly combined. Thank you.